let us start, okay?
Yeah, sure.
Hi, dear colleague. How are you all? I wish you all the best from Cairo, Egypt. I would like to see our country. It is very famous in historic places and everything, and kind people. I am very happy to meet together in this good webcast, and I introduce my thank for Professor Dr. Gigandib and Ponikar responsible people. Today, we will talk about a great implant. It is a compressive implant which become very famous in the media of the implant branch because the patient now like this type of implant because it secure him from the second surgery. The compressive implant is one single unit. The apartment and the implant are together with no with no second surgery to uncover the cover screw. So no simple trauma and flapless only with a very smart drill and suitable for all type of thin ridges and weak bone. And don't need for bone augmentation. Today, we have a good, very excellent implant, Boninkar. He has a very good advantage, have a dual threads, more than conventional compressive implant in the market. These dual threads lead you more stability, more self-tapping for the bone and suitable for all
ايه
type of bone.
سلام
And this implant also is very specific for narrow thin
Dr.
ridges.
Hashim, I'm so sorry I'm
Yeah.
interrupting you.
أجاوب بالعربية أجاوب بالعربية.
Can you please speak in Arabic language? Is it possible? Because the maximum audience is Arabic. We
You want
understand Arabic
Arabic?
language.
You want in Arabic
تمام
language?
تمام
Yes, sir. Yes, sir. Please, if it's possible.
Okay. Uh,
Thank you.
النهارده today we will talk about compressive implant. النهارده هنتكلم على الكompressive implant عباره عن سنجل بيس واحده يونت واحد بيجي في مقاسات مختلفه from 3 ملم diameter till to 5 diameter وما بنحتاجش ان احنا نفتح اللثه تاني سكند سيرجري عشان نكشف على الكفر سكرو. فدي بتخدينا فرصه ان الاستروما ما بنعملش فلاب للثه وطبعا ما بيحصلش سويلنج للمريض، وطبعا المريض في الحاله دي بيقدر ينزل with no problem او ما عندوش اي ورم اي سويلنج اي التهابات او كده. النوع هذا من الكومبريسيف مناسب جدا suitable for all type of bone كل انواع العظم من اول النارو ريدج للنارو سين ريدج لغايه الفلابي لغايه شورت بون and نقدر نوصل للثبات لدرجه 50 نيوتن على العظم اللي هو السوفت ده والفلاب ده، ونقدر نوصل لتورك عالي جدا يوصل ل 50 55 نيوتن ونقدر نحمل عليه ذات الوقت. احنا دلوقتي عندنا مشاكل مرضى كتير جدا بتجيلنا في العياده عندهم مشاكل ان محتاجين زرع عظم. آه.
كنسل ميوت كنسل ميوت.
السلام عليكم دكتور هشام، لو سمحت الصوت انت عامله ميوت.
اوه كل ده سيمبل ليستروما فلابلس اونلي، يعني نقدر نحط الامبلانت من غير ما نعمل فلاب، ونقدر نعمل دريلينج وذ سمارت دريل 1 and drill 2. In soft bone we put only smart 1, and in hard bone we drilling with drill 1 and drill 2, and sometimes we need countersink. So when we put the implant, we put it by my finger and with carrier until
Hello.
put it in the drill. Yeah.
Hello, sorry, sir. Sir, there are many students who want to, understand in English. We can't understand you.
Do you want English or Arabic?
English, sir. So many are writing in the chat box. They all want in English.
Okay.
Yes, sir.
Okay.
بس في عرب كثير، بدنا عربية.
Arabic and English, please. Okay. English first and then Arabic. Okay. Again. This I will say English and Arabic. Okay.
Yeah, you might.
Okay.
تمام.
I told you this implant is very simple because less trauma. فلابلس بمعنى عربي ان هي التروما بتاعتها للعظم خفيفه، مش محتاجه ان احنا نعمل فلاب. نو فلاب، نو بون اوجمانتيشن، مفيش زراعه عظم، وبنحصل على سترونج برايمري ستابيليتي، يعني الزرعه بتبقى ثابته قويه جدا، بتوصل 50 نيوتن. Strong primary stability reach to 50 Newton or more, 55. Make you immediate loading, especially in full arch rehab. نقدر نحمل عليها فك كامل والمريض ينزل يبتسم with great smile in the same day. احنا عندنا هنا زرعة بونكار have a great advantage more than another compressive in the market. بونكار have dual threads، معناها بالعربي موجود فيها these threads facilitating انك نعمل insertion ان الامبلانت يدخل جوه العظم very easy with no hot generation, with no problem, with no anything, and the patient no swelling. المريض ينزل مرتاح بعد الزرع لانك انت ما بذلتش اي مجهود في الدريلنج، جاست 1 اور 2 دريل بالكتير، يعني دريلين وبالاكتر، وبنقدر نوصل اللي احنا عايزينه. الزرعه دي مميزه فيها تميز كتير. Another advantage in boning car is all compressive implant in the market can bendable to 20 degree maximum in one direction. In boning car we can bending نقدر نتنيها to 45 degree لغايه زاويه 45 to be with a long axis with occlusion. نقدر نتني الزرعه 45 degree 45 درجه عشان تمشي مع الاوكلوجن بتاع الريدج. بتدينا سترونج برايمري ستابيليتي، بتدينا قوه ثبات عاليه جدا جدا جدا. نقدر immediate loading، يعني نقدر نحمل عليها الفول ارش بريدج in case of full arch rehabilitation. All fixed together. الكوبري البورسلين اللي احنا هنعمله، البريدج اللي هنعمله، الزراعات دي يجب ان تبقى fixed together. نقدر نعمل لها fixed together ازاي؟ ان احنا بنعمل بريدج كاستد ميتال covered with porcelain or zirconium، متغطي بالبورسلين. نقدر نعمل شاسيه معدن.
ممكن تفتح الكاميرا بتاعتك نشوفك بس، الله يكرمك.
ومش شايفيني؟ It's okay. in the dual threads of boning car give you self tapping of the implant inside the bone. ان الزرعه فيها خاصيه انها اجريسيف، انها حاميه، الثريدز بتاعتها حاميه، وانت بتعمل دريلينج when you drill the implant, torquing the implant inside the socket, it move easily with no any resistance. ده كل اللي اقدر اقوله، ان احنا نقدر في هذه الزرعه نعمل ريستور لسنجل توث، نقدر نعوض سنه، نقدر نعوض we can restore one tooth, we can restore quarter, we can make a primary excellent stability in full arch rehab. This type of implant, compressive implant, surface treated for better disintegration and to reduce bacteria migration. High stability, as I said, with fast insertion, low trauma, no swelling. طبعا زي ما احنا قلنا ان الخصائص اللي موجوده دي في الديوال ستريدز and بيندبل، نقدر نتني الزرع لغايه زاويه 45، بتدي قدره ان انا انزل very simple, very qualified to be compatible with bone and with the long axis of the jaw. In case of hard bone D1 D2، في حاله العظم الدنستي بتاعته عاليه، اللي هو كثافه العظم عاليه، احنا ما بنعملش سمارت 1 بس، احنا بنعمل سمارت دريلينج ويز سمارت 1، بنحفر بدريل 1 ودريل 2 وبنعمل كاونتر سينك، بنحاول نوسع السوكت انه ما يعملش اوفر كومبريشن، ان انا ما ضغطش على العظم زياده عن اللزوم فيحصل كراك. Be care, no more ratchet more than 50-55 Newton, because if you more, maybe the bone cracking and the implant failure. Bone preservation, zero bone lost after 5 years follow-up, and no periimplantitis due to the implant compatible with bone, the threads under submerged under the bone، الحواف الحاميه اللي بتاعت الامبلانت بتنزل تحت العظم، والجزء الناعم اللي هو النك، the neck is very smooth compatible with the gingiva with no bacteria contamination, no food accumulation, everything will be okay. And we follow the implant after 5 years، بعد 5 سنوات، no bone loss، zero bone loss، مفيش اي bone loss، مفيش فقدان للعظم، healthy gingiva and the bridge is stable. And we can see this in our cases and our video. Let us to see. Now we have a video in the left side how to make drilling in the socket without flap. We make first one, smart 1, smart 2, and in soft bone we insert the implant very easy. احنا في العظم الطري بنعمل دريلينج دريل 1 ودريل 2، وبعدين بعد كده بناخد الامبلانت insert the implant with cap driver by finger, and then after the implant catch it to the bone, I use the ratchet till to reach torque 55 or 50 Newton maximum, avoiding bone crack. Don't make excessive torque, avoiding bone crack. So because excessive torque make more compression، هتضغط على العظم اكتر وتعمل later failure ومشاكل احنا مش قدها. So in soft bone, smart 1, smart 2 like in video, and insert the implant in soft bone. And in immediate implant in case of extraction، في حالة الخلع الحديث احنا بنحط في البايفوركيشن او في الترايفوركيشن بتاع المولر، بنيجي في بايفوركيشن او ترايفوركيشن في انترسبتال بون، بنعمل دريلينج سمارت 1 دريلينج سمارت 2. لو البون سوفت بحط الامبلانت في الترايفوركيشن او البايفوركيشن في the middle of the socket with long axis parallel with the long axis, and then I insert the implant very simply, very easy, with little torque until I reach to, in case of immediate implant with extraction, try submerge the implant more 1 or 2 millimeter, because when the gingiva and the bone become healthy, the gingiva will recede and the bone will recede. So we keep the implant in immediate implant in case of extraction deeper in the submerged bone. In case of D1 and D2 bone, we make after drill 1 and after drill 2. بعد ما بنعمل حفر بدريل 1 ودريل 2 بنعمل كاونتر سينك. كاونتر سينك معناها ان احنا بنهيئ السوكيت اوف ذا امبلانت انه يدخل مرتاح من عند الكومباك بون عشان ما يحصلش كراك هو داخل. فاحنا بنريح دخول الزرعه، بنريحها. اللي فاهم اللغه العربيه يفهم يعني ايه بنزلها فيري سيمبل. فكاونتر سينك دي بتخلي no more compression for the bone. Let us see our cases and the video in my clinic, and I will everyone I will say a word, and I say make explain for the case and what they complain. Let us go. This now we make a drilling with smart 1 with a long axis with high colon. Keep the colon very high in the middle of ridge. This ridge is very thin, and this patient, all my colleague refuse to treat him unless he make bone graft. هذا المريض راح لدكاترة آخرين وقالوا له لا احنا مش هنزرع إلا لما نعمل بون جرافت، نزرع عظم. فهو رفض. He refused, and he come to me because he knows that I make single piece. I make for him all in 6 implant. I insert the implant manually to my finger and remove the cover screw, remove the cover mounting cover, and I put the ratchet like this, and I put 6 in grade parallels, and take the impression the same day. And I the same day I خدت المقاس في نفس اليوم. و this X-ray grade inclination grade parallelism, all the serration submerged in bone, and the neck only in the gingiva to be compatible with the gingiva. Next. This case, before he came to me, he visit many doctor, many dentists in the city, and then he make many implant before me, and he implant failed, and he come to me. I make X-ray for him. I found the bone like this, very soft, very thin. And I advise him to make a compressive implant because he need more stability. And then he make 3 implants in 4 and 5 area premolar, and in 7 area, and then I make a good bridge for him with great parallelism. This 5 years follow up, great. And this case visit me from USA. He came because he make many implants there, and his bone is very flabby, very thin, and I decided to make for him a compressive implant with a great high torque and very, very good full arch porcelain. The next day, he very happy and very, very, very satisfied. Let us see. Yeah, great parallelism. Great. Without surgical guide, by the way. I work hand by hand, no surgical guide. I used to use my hand. In the same day, we put 6 implant and loading the same bridge, you see? And he's very satisfied and he sent me greeting.
دكتور هشام سؤال بس لو سمحت.
Yes, تفضل.
How narrow the bone that we can do compressive implant؟ يعني اقل عرض للعظم نقدر نحطه فيه زرعه الكومبريسيف.
هو في مساء الخير الاول، في كومبريسيف النهارده في السوق مليان كومبريسيف مينيمم. احسن كومبريسيف تحطه 3 دايمتر. بس انت وانت بتعمل دريلنج بسمارت 1 سمارت 2، انت بتفتح البون حتى لو البون اقل من 3 مللي، فانت بتعمل له كانك بتعمل سبليتنج للبون. يعني انت بتوسع البون وانت بتحط الامبلانت جوه البون، بتعتمد على البيز بتاع الريدج. احنا بنعتمد على البيز بتاع، واحنا بننزل بعمل توركينج للامبلانت، هو بيوسع السوكت بتاعه وبيدخل. ولذلك 3 ملم diameter is very great in lower anterior lower, very compatible with the bone and no need for bone augmentation. Dry use only drill 1, drill 2 with very slow speed, high colon and little countersink. بتفتح العنق بتاع العظم، هتلاقي الزرعه نزلت معاك ممتازه مرتاحه. بس كيب يور هاند بارل، خليك خلي الزرعات متوازيه مع بعضها زي ما انت شفت في الاشاعات كده. يعني على قد ما تقدر ما don't be depend on bendable implant. Be parallel as you possible. But if you want bend, okay, this implant boning car can bending 45. نقدر نتني boning car لغاية 45 درجة.
السلام عليكم.
This case عليكم السلام، اتفضل.
ممكن نشرح النيرف باس تكنيك؟
نعم.
النيرف باس تكنيك لو سمحت ممكن؟
احنا كلامنا هنا على الكومبريسيف وعلى البيزل، فمش يعني ممكن المحاضرة الجاية.
اوكي ماشي.
ممكن بعد استسمعك المرة الجاية، احنا المحاضرة الجاية بعد يعني ان شاء الله هنحطها في المقدمة. دي حالة جات لي اول امبارح 2 days before this case came to me. No bone, no ridge, as you see. Very flabby, very thin, and I decided to put for him 6 parallel compressive implant. And in 20 minutes, we finished the case, as you see. Great case. All serration under the bone, submerged to bone, and the neck, you see. Next week, he will we make the maxilla too.
Full mouth or دكتور؟
This what؟
ده الكيس الاول. اول شيء السلام عليكم.
السلام عليكم.
دكتور اكرم علي من اليمن. الكيس الاول اللي عرضته،
اهلا بالحبايب.
اهلا وسهلا فيك. الكيس الاول اللي عرضتها كانت اول ان 6 يعني كيس.
انا كل شغل
عاده احنا نركز على الاول ان 6 في الانتيريور ريجن.
احنا دايما انا بشتغل اول ان 6 واول ان 8. انا بحب في الكومبريسيف احط اول ان 6 اول ان 8. في حاله لو انا هقف عند ال6 بس بحط اول ان 6 او اول ان 8. لو في حاله ان انا هقف عند ال7 بحط اول ان 8. في حاله دلوقتي جايه اول ان 8 هتشوفها حلوه قوي قوي قوي.
تمام معاك.
دي هنتكلم على الحاله دي. الحاله اللي قدامنا دي كل الدكاتره رفضوا يعالجوها. This case all my colleague refused to treat it because no bone, only 2.5 millimeter in the ridge. And when I put the implant, I decided to put in the obliquely to the ridge. Yeah. My friend will discuss to you the basal implant. I make this implant the way of the basal. I put it obliquely, and then I bended the implant to be with the long axis of the arch. Because no bone in the ridge, no bone. Really, all dentists say to her, you have to make bone augmentation, and she refused.
دكتور هشام لو سمحت،
اتفضل.
في حاله ان احنا دخلنا اوبليكلي ايه البوينت اوف انتري؟
My friend will discuss the basal implant, but for me, I put in the if the molar I put it in the ramus area obliquely about 30 degree or 35 degree to avoid the nerve, and try to find compact bone because she's scared don't have really ridge bone. Really, no ridge, maybe 1 millimeter or 2 millimeter maximum. The minimum implant diameter here is 3 millimeter. If I try enter the 3 millimeter, it will be exposed in gingiva and it's not good. So I use the compact bone to be the housing of the implant. And my colleague Gigambi will discuss to you now the basal implant. And your question will be find the answer with him now.
لو
This
سمحت
case, اتفضل.
دكتور هشام، لو سمحت حضرتك بالنسبة لنوع الزرعة والمستخدمة the type of implant and the type of titanium، لو كان المعدن ما كانش كويس أو التيتانيوم ما كانش الزرعة كويسة، هل ده يعمل لنا أسباب الفيلير في
ما هو
الزرعة؟
طبعا انت ما تروحش تجيب زرعه تيتانيوم 3 او مش معمول لها سيرفيس تريتمنت كويس. هتبقى اول 6 اشهر او سنه كويسه، فيرست 6 مانثs او فيرست يير، وبعد كده هيحصل لها بول لوس. اهم حاجه انك انت تعمل 5 years فولو اب، هتلاقي الكريستال بون زي ما هو ده المهم عندي، انك انت
طيب
ما
ممكن
تفرحش.
أنواع الزراعات اللي في السوق أو حضرتك تنصحنا بيها الموجود، في حاجة معينة ترشحها لينا أو
انا دلوقتي انا استخدمت كل انواع الكومبريسيف بصراحه. I used all the compressive type, but I found in the boning car a very good advantage, really.
بونينكار؟
Boning car first advantage is bendable for 45 degree. It is no compressive in the market can bendable more than 20. If you try to bend more 20, will broken. Boning car 45 degree can bending it to be with the long axis. The second advantage of boning car is dual threads, very good and aggressive, and you self tapping. If you find some resistance of bone، لو انت لقيت مقاومه في العظم، هو dual threads اللي موجوده فيه ده بيعمل سيلف تابنج كانك بالظبط يعني مش مطحنه. يعني انت وانت بتاخد بتطحن العظم وبتكبسه، تعمل له كومبريشن، مع انك انت بتعمل له تورك 45 50 55، بتقدر تعمل immediate loading في نفس الوقت، والعيان يبقى لازم ساتسفايد. لان المريض حضرتك ما يهموش انت هتعمل ايه، المريض اللي يهمه انه ينزل بسنان من عندك. الناس كل الناس بتجهل ان المريض كلمه بون اجمنتيشن بالنسبه للمريض دي مزعجه جدا. هو جاي لدكتور السنان عنده غرض واحد بس، انه يعمل سنانه ينزل بسنان. he want teeth. The patient come to the dentist ask for teeth.
دكتور هشام سؤال لو سمحت. نحن حكينا على العرض البون، يعني we talking about the width of the bone 3 ملم. باقي الهايتس نتاع الكمبريسيف اللي تحققها اقل هايت
الكمبريسيف 6 ملم. diameter of compressive is 3, 3.3, 4, 4.5, 5, and 5.5. For the lens is 6 millimeter, 8 millimeter, 10 millimeter, 12 millimeter, 14 millimeter, 16 millimeter for normal compressive for in the market and for boning car also. But there is 32 and 28 lens for the basal. My colleague will discuss to you after I finish my video. Now we have a last case. We have last case. Patient come to me with very loose teeth, and she asked to me make a bridge. I advise her to make 4 implants every side, and I remove the mobile teeth, all the teeth removed, and I put the implant inside the socket like you see now. Every side make 4 implants. في كل جنب حطيت 4 implant with great parallelism in the socket of extracted molar and premolar, and I make in the same day full arch bridge porcelain on metal. You see parallelism, great parallelism without surgical guide. No surgical guide here. My hand. You see the parallelism? You see?
دكتور سؤال ثاني، سؤال آخر يا دكتور. after extraction يعني immediate implantation، التورك اللي نقدر نحققها في الامبلانت اللي هي compressive implant عشان نعمل عليه لودنج، اقل تورك قداش؟
اقل تورك 45 نيوتن، واكبر تورك ممكن توصل ل 60 65 and no more.
يعني لو 35 يا دكتور.
No immediate load.
No immediate loading.
35 نيوتن no immediate load.
بعض الكتب بتقول 35 start 35.
Lateral incisor only.
Lateral incisor only.
No stress bearing area.
Please, what are the cases in not full arches? If we are doing just only one arch or one right side or left side, what are the يعني شو هي المعايير, the criteria for placing the implant if not doing full arches?
In full arches.
How many implants? No, I mean لو حطينا يا دكتور في ناحية واحدة فقط الزراعة, يعني مش هنحط في ناحيتين, او مثلا هنحط مثلا الاسنان اللي تحت موجوده الانتيريورز بس البوستيريور مش موجود, تمام, وهنحمل على الطرفين, مش هنعمل فول ارش, هنعمل ليفت ارش, ويعني هنعمل البوستيريور على اليمين وليفت بوستيريور اند رايت بوستيريور.
انا فهمت قصدك.
تمام.
انا بحط في المولار اريا في الحته دي بحط 2 امبلانت في المولار اريا. لو العظم 2 implant in molar area and try to wait, استنى 45 يوم. ما تحاولش, don't load in the way of quarter bridge in the same immediate load. Don't make immediate load. Try to wait 45 days and then make a bridge from the natural teeth في حالتك دي والتو امبلانت في الاخر. في الحاله دي تبقى ناجحه. ما تحملش على واحد بس ناتشرال، لانه هيحصل له هيتلخلخ، هيحصل له لوزنج. انما في الحاله دي بتعمل فيكسد بريدج. في حاله مثلا لو تاخد القناين والبريمولر مع التو امبلانت في مولر اريا، انا عملتها كتير ونجحت وبقى لها سنين، بقى لها اكتر من 15 سنين.
طيب ضروري نعمل اندو للكناين مثلا؟
يا فندم
ضروري نعمل اندو لحضرتك لو ممكن نربط زرعه بسنه.
زرعه بسنه؟
كان وي كونكت
يعني عنده ميسنج ايه؟ قول لي عنده ميسنج ايه؟
حضرتك عنده ميسنج ال4 5 7 8.
لا انت عشان تحط المولر اريا
So
مينيمم
you
تحط
want to make 2 implants.
في المولر اريا لازم على الاقل تحط
Yeah.
2 امبلانت او 3 امبلانت في المولر اريا في حاله الكومبريسيف.
Doctor,
Okay.
hello.
Hello.
Sorry to interrupt, but can we keep the question and answer discussion for the last?
Okay.
We can wrap up the presentation.
سؤال اخير
We
دكتور،
can
بس
keep the question in the last.
سؤال اخير يا دكتور.
اتفضل.
لما نحصل على سبيل المثال تورك 30 نانو سنتيمتر، ما نقدرش نثني الزرعه نستناها لعند بيصير هيلينج ما قبل الثاني عشان نعمل ليبراليزم.
لا انت بتعمل بيندنج في الزرعه في نفس الوقت اللي انت زارع فيه. اول ما تزرع وعدى يوم مريض خرج من عندك ما تلمسش الزرعه تاني. لو حاولت تعمل بيندنج بعدها بيحصل فيلير.
شكرا دكتور، شكرا.
اوكي. ثانك يو سير. ثانك يو
معلش
كوليج.
دكتورنا last question. يعني 45 torque is the minimum for the loading, immediate loading. أما 35
no
delayed.
35 no 45 minimum and in full arch rehabilitation very necessary to fix all the implant together in one mean soldering in one bridge. Soldering and joining together, it will help all the force with the mastication and with muscle and everything will help for more success, more shelf life for the bridge.
دكتور هشام لو سمحت، هو البونين كار في السوق المصري؟
نعم.
البونين كار امبلانتس موجوده في السوق المصري؟
داخله السوق المصري بقوه جدا، وهتشرف ان شاء الله ان انا ماسك الميدل ايست. هبقى مسؤول عن مصر وعن ليبيا وعن السودان وعن الميدل ايست، والحمد لله تم الموافقه على هذا.
كان في مؤتمر امبلانتس موجود في جامعه الازهر قريب، ما شفناهاش فيه يعني.
لسه احنا لسه ان شاء الله في اول يناير هيتم البروتوكول الرسمي بيننا وبينهم، وهتدخل بقوه جدا لان هي زرعه ناجحه جدا 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 جدا. لان انا جربت كل انواع الزرع اللي موجود في السوق. I use all the type of compressive in the market from USA to Turkey to Germany, everything. But really the advantage of bowling car make me more proud of
دكتور بعد اذنك كنت عايز اسالك سؤال. in case in one ambulance
نعم.
immediate loading بعد قد ايه؟
السنجل
بيس.
لا سنجل يونت ولا فول ارش؟
سنجل يونت.
لا سنجل يونت محبذ. ان سنجل يونت محبذ ليك انك تعمل تمبري كراون، فري اكلوجن، فري كونتاكت، ليتل سلايد، نحط كربونه وانت بتعمل الاوكلوجن، وانت بالاوكلوجن اعمل دبل كربون، يعني بحيث ان ما يبقاش فيه اي تاتش عليها.
اوكي.
انما انت لو عايز تعمل، لو حضرتك عايز
امتى؟ البيرمننت بروسيس امتى؟
لا انت في السنجل بيس مش محبذ انك تعمل فاينل كراون في نفس
الفاينل
تحط
كراون
تمبري
يبقى بعد قد ايه؟
بعد 45 يوم.
45.
انما في الارش ريهاب تقدر تحمل الفاينل بريدج في نفس الوقت، لانك انت عملت فيكسيشن ما بين ال6 او ال8 امبلانت، وكله مع بعضه بيقوي بعض، بيعزم بعض، كله بيدي
انا دايما
مع
بعمل سولدرنج لما يكون فول ارش، بعمل سولدرنج
بالبريدج. انت بتعمل البريدج ده نفسه سولدرنج، يعني يعتبر انت لما بتعمل بريدج بورسلين او بريدج على ميتال وتحط عليه زركونيوم، انت كده كانك عملت سولدرنج، لانك انت كله ماسك في بعضه كله.
even bridge to implant برضه 45 يوم.
45 يوم كوارتر 45 يوم 45 days. فول ارش ريهاب I put it in the same day.
دكتور بالنسبة للإمبريشن سكرو ولا سيمنتد كلها
لا مفيش سكرو، ده ما فيهوش سكرو.
Again
الامبريشن كيف يعني، وهل هو الفكس البريدج حيكون سيمنتد بس يعني؟
ده وان بيس.
لا الوان بيس في انت تقدر تعمله سيمنتد، وتقدر تعمله في جزء بيتباع تاني بيركب على الاباطمنت بتاع الوان بيس، بتخليه ريتين. يعني في جزء تاني انت بتحمل عليه جزء تاني وبتربط، وممكن تعمله ريتيند بريدج، ان هو بتبقى سكرو ريتين. بس انا حقيقي بحب السيمنتد بريدج في نفس التوقيت وفي نفس الوقت، لان انا ما بحاولش في الكومبريسيف اعمل مينتيننج في الكومبريسيف، هو عامل مينتيننج لنفسه.
Hello.
Yeah.
Can you please ask him to ask the question in English?
Yeah.
Some of the members are not comfortable. They are comfortable in English. So can you please ask them to ask the question in English, if possible?
You're welcome.
لو سمحت يا دكتور بونينكار, what the nationality of the implant?
Sir, it's an Indian company.
Indian company.
Indian.
We deal in whole of the world. We are an India-based company, but we deal in whole of the world. We are an international company basically. Our headquarters are located in India. The headquarters are in India. The company is international.
Okay, it's not found in Egypt until now.
We are beginning our operations in Egypt. It will be available in a very short time now.
Okay.
Also, you can give us your contact. We are also providing the sample implants. So if you want one, you can take the email ID or the number of the company, and you can WhatsApp us, and we will also send you the free sample of the implants. If you want to try our implants, we are providing 3 to 4 implants at free of cost, no charge. You can use the implants and put it in your patient and see the results for yourself.
Okay, please, can we contact and the Poninkar information on the?
I am just sharing it on the screen right now. Take a screenshot of this. I hope my screen is visible.
Okay.
My screen is visible?
No, just 1 minute. Yeah. Okay.
Take the screenshot. There is the email ID. There are the phone numbers and
this is the contact
and the website. Okay, you can WhatsApp on any of this number, and a sample will be sent to you on your address, free of cost, no charge.
Okay, thank you very much.
Anyone else also want? They can take a screenshot of this contact number. Now I will begin my presentation, and we will keep the question and answer round for the last. Okay. Any questions, either Dr. Nasir or to me, will be answered in the end.
Can we get number of Mr. Dr. Hisham, please, also?
He will also share you in the last.
Okay.
What you say?
Okay. So I am beginning my presentation now. My screen is visible to everyone.
من فضلك والله كنت عايز اسال الدكتور هشام. من فضلك والله من فضلك.
Hello.
كنت عايز اسال الدكتور هشام.
My
كنت عايز
screen is
اسال الدكتور
visible.
هشام. سؤال للدكتور هشام.
Yes.
I am beginning now. If you have any questions, please try asking the question in English. Okay, I will continue. And if there is any doubt in understanding my language, Dr. Nasir will help you and translate my English to Arabic. Okay. So I am
Thank
beginning
you,
my
colleague.
presentation now.
Thank you, colleague. I'm very happy for this meeting, and I'm very proud of you and proud of all the question and answer. And I hope that you get my words and understand what I said, and you be enjoyed with my video.
That was a very great lecture. Very nicely done cases. I am very I like your work, how you do the cases. I really like
And
them.
I would like to thank Mr. Professor Mufti and Professor Zawahri to his presentation with us, and his thanks for your presentation, and you are great. And thank you. And they say to me, thank you, Mr. Gigan, and your great implant. Thank you, and I'm very thankful for all the team. And we hope to meet another webcast soon. Thank you.
لو
Thank
سمحت
you.
ممكن نمرتك يا دكتور هشام بعد إذنك؟
دكتور هشام
ممكن في رسالة تبعت لي على رسالة. بعت لك
تبعت لنا.
الطاقم المساعد بعت لك على رسالة على الماسنجر عندك. في المسج عندك. في المسج عندك.
اوكي انا
انت منين
دكتور علي
حضرتك؟
علاء الدين.
انت منين؟
انا دكتور علي علاء الدين، انا من سوريا بس مقيم في مصر.
اهلا وسهلا. اي شرح او اي استفاء، احنا تيم ورك كامل مع بعض وان تيم، ومعانا الاستاذ الدكتور محمد المفتي، ومعانا الاستاذ الدكتور محمد الظواهري. دول اساتذتنا وعلمائنا، واتشرف ان اكون من نفس مدرستهم، ومنورينا هم حاضرين معانا البرزنتيشن. واتمنى يعني يكونوا مبسوطين بيكم ومتشرفين بوجودكم هم كمان زي ما احنا متشرفين بيهم يعني. واي وقت تحت امرك. المساعد بتاعي بعت لك الرقم على المسج.
هو دكتور يوسف هشام
and ابراهيم هشام يعني.
تمام.
Yeah, he's my son and my assistant.
تمام يا دكتور. Please, there is any books you ترشحهم لينا؟
Yeah.
books
نخلص بس نكمل المحاضرة، وممكن تجي لي بقى انت بعد كده على الرقم اللي بتقول. اوكي
ماشي يا دكتور. شكرا.
لا تحت امرك. Sorry professor about delay your presentation. Sir Gigantba.
Can we begin now?
Yes, go ahead. Thank you very much. Thank you, my colleague. Thank you.
Sir, you will be there with me now. Don't disconnect the call yet.
We are here. Start. Go ahead.
So I welcome you all on the behalf of Bonanker Implants. As we said, we are an Indian-based company dealing internationally. We specialize in compressive and basal implants. We have developed our own series of implants, and I will be sharing these implants with you shortly. So welcome you all. I am Dr. Gagandeep S. Gabba. I am the Technical Director and Surgical Training Mentor with Bonanker Implants. If anyone has any trouble understanding my language, you can please ask me, and Dr. Hesham is with us, and he can help you understand my language if you have any trouble understanding English. Okay, everyone is comfortable in English? Is everyone comfortable?
Yes.
Okay. So
dear colleague, if someone want to ask Arabic question, he can ask, and I will translate for Mr. Gigandim. Okay?
Shall I continue now?
Yes, please continue.
Just wait a minute. There's a problem with my system. So, what is the philosophy of our system? Our system is based on the philosophy that we don't do any kind of bone grafting. We are a no bone grafting philosophy. We use only the native bone, what is present in the patient, whatever the anatomy, shape, size, or density of the bone. We don't do any kind of bone grafting. Our implants can be done in healed as well as fresh extraction sites. Everything is possible with bone anchor implant system. We provide immediate loading in all of the cases, irrespective of anything. Immediate loading is possible in every case that may come to your clinic. And we have basically developed a dual thread technology, or our implants, as Dr. Hesham mentioned, all our implants have a dual thread that gives enhanced anchorage. They give a better load bearing capacity to the implant. They give a better pull out strength and elevate the longevity of the implant. That is, the survival of the implant is very high. Many of our cases that are done a lot of years back are still surviving and still thriving very good. All majority of our implants are smooth surface implants. There are a lot of advantages of putting the implants in smooth surface, and we only provide single piece construction. What are the various advantages of it? I will explain to you in the coming slide. So this is the no bone grafting concept in basal implantology. So there is a saying, whenever the bone grafts come in, the predictability of the treatment goes out of the equation, because we are relying on the biology of the patient, that they may accept the bone graft or they may not accept the bone graft. The body we have to rely on. If the body rejects the bone graft, we have no choice. The implant will fail, the bone graft will fail. So what are disadvantages? It gives the unpredictability to the treatment. Otherwise, it is also expensive to the patient as well as to the doctor. And most of the time, when we graft the bone, the implant is done in the second sitting. So there is a need for second stage surgery and the cost. So what we have done is we have developed various implant designs to accommodate the bone presented to us, not the other way around. So what we do is we don't modify the bone. We don't modify the bone to fit one kind of implant. We have a selection of implant, and we select the implant according to the clinical scenario, right? So we have a lot of implants, and we select the implant on the basis. These are the various implants that are presented in our catalog. Okay, so basically each implant is suited for a particular clinical scenario. So whatever kind of scenario we see in the patient, we select the implant accordingly, not modify the bone to fit in the implant. And most of the implants are presented in the smooth surface, that is also known as ad modem brandmark surface. That is the original surface that was developed by the brandmark. Everyone know about the ad modem brandmark surface? So this is the original surface that was developed by brandmark. So what are the advantages here? The advantages is there is no risk of peri-implantitis. It can be used in diabetic patients, can be used in smokers also, can be placed after extraction of periodontally infected teeth. Because when the teeth are periodontally infected, so what happens is, because of the infection, when we place the rough surface implant here, so what will happen is the implant will also get infected. When we are using a smooth surface implant, Hanji, yes?
सर आपका कैमरा नहीं वर्क कर रहा है.
Now it's fine?
Yeah, now it's fine. Thank you.
Just wait a minute. I am setting up my tabletop camera. The phone actually switched off in between. So, right, fine. So the implants can be done in smokers as well as diabetics where the rough surface implants fail. Okay. and it can be done in both extraction socket as well as delayed loading cases. Reintegration of the implant is possible. If the implant fails due to any reason, the same implant without removing can be reintegrated in the bone. Removal and replacement with wider diameter is possible because of smooth surface implant. Single piece construction. The implants provided by us are monoblock implants that they are made from a single piece of titanium. So what are the advantages? There is no screw, hence there is no screw loosening, there is no screw fracture, there is no implant fracture, there is no micro gaps at the implant abutment complex, hence no peri-implantitis, and there is no crestal bone loss in smooth surface implants. Any question till now? Right.
Yes,
So these
please.
are,
What's the difference between basal and compressive?
okay, you can see the slides. So the implants on the left side, these implants are the basal implants. And how are they different? I will be showing you in the coming slides. These are the compressive implants.
Please, no can see the slide.
My slide is visible, I think.
Yes.
My slide is visible. Can you see the implant photos on the screen?
Not visible. No, not visible. Not screen.
Anyone? Dr. Hesham?
Yes, it is visible.
It's visible. Ma'am, there is a connection in your, there is trouble in your connection. It's visible to everyone else. Okay, so I'm continuing. So these are the various implants. The implant we see on the left are the basal implants. The implants we see on the right are the compressive implants. So there are various names. The first one is basal classic. This is the basal varios. This is the basal vampire. This is the basal tornado, and this is the varios X. And this is the pros, and this is the pros pro. We will study each one in detail in the coming slides. So as I told you, we have an implant for every situation. We don't modify the bone to fit in the implant. We select the implant according to the bone, right? So before we begin, we must understand some definitions. So first one is, we are studying about what are basal implants. So we must know what is the basal bone. Okay, the first definition is, what is basal bone? So basal bone is the dense, stable bone that remains after the alveolar bone undergoes resorption. When all the alveolar bone is gone, when everything is gone, whatever is left is the alveolar bone. Okay, so everything is resorbed, only this bone remains. This is the base of the alveolar bone. This
Hello,
never
sir.
get.
Hello.
Hello.
So your
Yes.
slide is not working. I can't see the slide.
Ma'am, I think everyone else is visible. If there is a connection and there is a trouble in your connection, everyone else
Okay.
slide is visible.
Yes,
Yeah,
visible. Yes, visible.
Slide is
Okay, okay.
visible to
Yes,
Let me
everyone.
check.
visible, but on
Let
other
me check.
side,
You,
yes.
you just log out and rejoin. Okay.
Okay, sir. Okay, sir.
So basal bone is when all the alveolar bone is resorbed. Whatever is left is the basal bone. Okay, clear to everyone? So
Okay.
this is the residual ridge resorption in maxilla and mandible. As you can see, after a tooth is extracted, the alveolar bone undergoes rapid resorption, and what is left in the end is this bone and this bone. You can see not much height is left. So this is the basal bone, and our implants rely on the basal bone. So these are the various basal bone that are present in the maxilla and the mandible, right? We will study these one by one. In the maxilla, the firstly we have very important, that is a nasal cortical floor, that is the floor of the nasal cavity. As you can see here, this is the floor of the nasal cavity. So this is a very important basal cortical bone in the maxilla. Secondary, we have the anterior wall of the maxillary sinus. As we can see, this is the anterior wall of the maxillary sinus. After that, we have the floor of the maxillary sinus. We can also engage the implant because the implant is a smooth surface implant. As I said, the implants are smooth surface implants, hence they can be engaged in the maxillary sinus and there is no problem with the infection. We have the posterior wall of the maxillary sinus, and we also have the pterygoid bone. We can engage the implant in the pterygoid bone as well. Extra maxillary, we have the zygomatic bone. We can engage the implant in the zygomatic bone whenever there is no bone left in the anterior region. In the mandible, we have the base of the mandible, okay, the base of the mandible in the body. Then we have the lingual cortical on the lingual side, and then we have the body of the mandible in the interforaminal region. Now we will see this on the models. Can you please switch on to my tabletop camera? Can you please switch on to my tabletop, Nishta ma'am?
You mean the desktop demo of the various basal cortices?
Yeah.
Okay.
Can you see the tabletop, Nishta ma'am?
We see the tabletop.
These implants are visible?
No. We see your face and the desktop. I mean the demo of the various basal cortices.
Yes, sir. गगनदीप सर?
हाँ जी मैम.
हाँ सर, आपका सर टेबल टॉप विजिबल है?
मैम ये कह रहे नहीं है, उनको डेमो ही आ रहा है.
हाँ सर, विजिबल तो है.
नहीं, वो कमेंट भी आ रहा है नीचे.
So visible to here.
हाँ विजिबल है.
Visible.
Yeah.
विजिबल है.
to everyone?
Visible to everyone.
Right. I'm just coming back to it now. So what we can see here is I am putting the implants aside for now. So this is the maxilla. Okay. So this is the nasal cortical floor. Okay. Everyone can see.
Can you zoom in or magnify?
Where?
Small. Can you show?
You see the maxilla.
Yeah, we see.
Now it's clear.
Now it's clear.
So this is the nasal cortical floor that we can engage the implant in. Right?
Not
So
visible, not visible.
On
Not
the second
Not visible.
Demo where is basal?
بتنزل لتحت حتى
Demo various basal
सर
cortices.
आपका टेबल टॉप नहीं दिख रहा है सर, स्क्रीन पे सिर्फ डेमो ऑफ द वेरियस बेसल कॉर्टेसेस ये लिखा हुआ दिख रहा है सर.
Nishta ma'am.
So, how many people can't see?
I can't see.
गगनदीप सर सिर्फ डेमो ऑफ द वेरियस बेसल कॉर्टेसेस यही लिखा हुआ दिख रहा है, जो आप मैक्सिला दिखा रहे हैं ना वो नहीं दिख रहा है सर.
मैक्सिला कुछ नहीं दिख रहा है.
Demo of the various basal cortex. Only.
We can see, sir, now.
Can you see?
Can you see now?
You are seeing only the screen where the demo of the
Now it
Demo of
cannot.
the basal.
Now it's
Go
visible.
down, you will see.
Yes,
Go
it
down.
appears now. It's good.
Yeah. Now.
Yes, good.
Yeah.
Good, yeah.
Now.
Yes.
Yeah, the maxilla.
Very good, sir.
The nasal bone.
Right. So this is the nasal floor. This is the
Nasal
primary
Can you
nasal
enlarge,
cortex.
please? Enlarge the view, please.
It can't be enlarged. It's already on 2x.
Okay.
Okay. So I can show this now. This is the. Okay. So we can engage the implant here, or what we can do is we can engage the implant in the anterior wall of the sinus. Okay. Or we can do is we can engage the implant in the floor of the sinus, or we can engage the implant in the distal wall of the sinus. Or what we can do is we can engage the implant in the pterygoid area. This is the pterygoid bone. Everyone is aware of the pterygoid. So what we can do is we can engage the implant in the pterygoid bone. What we do is we engage in the medial pterygoid. This is the medial pterygoid bone. Okay, this is the junction area. So we try to engage in this point. This is the fusion zone. This is called the fusion zone, where the medial and lateral pterygoid meet. This is the fusion zone. So what we do is we try and enter from the tuberosity. We try and enter from the tuberosity here to pointing towards the pterygoid, and then we can place an implant over here engaging the pterygoid bone. It's clear to everyone? I will demonstrate placing of the implants in the model in the coming slides. Okay, I am just displaying what are the various basal cortexes present in the maxilla as well as the mandible. So I will be displaying each and every step how to place the implants in the following slides. Now we will move on to the mandible. In the mandible, what we can do is we can place the implant through here till the base of the mandible. Okay, this is the base of the mandible. In the interforamina region, between the two foramens, okay, this is the one foramen, this is the other foramen. In the interforamina region, either we can do is we can engage the implant in the body of the mandible, or we can go through hole and rest the implant on the base of the mandible. Okay, and apart from that, what we can do is we can engage the implant in the lingual cortical just below the mylohyoid ridge. This is the mylohyoid ridge. Everyone can appreciate the mylohyoid ridge.
Yes.
So this is the mylohyoid ridge. What we can do is, because the nerve is always below the level of the mylohyoid ridge, that is the beauty of the mylohyoid ridge. The nerve is always present below the level of the mylohyoid ridge. So what we can do is we can start drilling from this side, okay, and exit on this side, engaging this cortical, and there is never a chance to hit the nerve. So how it's done, I will display it all in the coming slide.
So it must enter the cortical bone. It cannot be on the top bone.
No. It should always be entering the cortical bone. I will show you in the coming slides. So what are the basal implants? So basal implants are the implantable devices that anchor in the basal cortical bone, right? We have studied what are the various basal cortical bone present. So basal implants are the implantable devices that anchor in the basal cortical bone and acts as a surgical post for the placement of the crown, bridges, and full arch prosthesis and other semi-fixed prosthesis. Okay, so what are basal implants? These are the implants that anchor in the basal bone. As simple as that. One line definition. Everyone can take a screenshot of this slide. It's clear to everyone?
No, sir.
Yes.
So what's the doubt? What is the doubt? Okay, I'm
The
continuing.
ambulance in the senior. The
Is there any
ambulance in the
trouble?
seniors.
What you are saying?
The ambulance in the senior.
Okay.
I'm not able to understand you, so I am.
Okay, now I see slide.
Now you see?
Yeah.
Okay, so this is the conventional implant. The conventional implant is only present in the alveolar bone. But what we do is in basal implants, we drill through and through. We pass the cortical bone and the second cortex, that is what we engage. So then it becomes a basal implant because we are anchoring second cortex. Right?
Must enter the sinus, sir.
I will give a demo of the basal implant.
It must enter the sinus, you mean? Or the cortical? How can we differentiate the cortical bone and the sinuses?
Here in sinus, there will be sinusitis or membrane will be ruptured.
It's sinusitis or no?
Because it's a smooth surface implant, so there will be no sinusitis.
tear of the increase of tear of the membrane?
Even if there is a tear of the membrane, the implant will the membrane will overgrow on the implant.
Okay. Okay.
My screen is visible.
Screen is visible. Yeah.
Yes.
No.
So what I am telling is there is a concept everyone should understand. I will write it down. So the concept is R1, D1, R2,
D1.
D2. R1, D1, R2, D2. So what happens is, suppose this is the maxillary anterior. Okay, this is the alveolar ridge. Okay, this is the nasal floor. Okay, so what we do is we start drilling from the alveolar ridge, and here we will feel a resistance. So this is the resistance one because this is a hard bone. Okay, when we perforate it, we enter the soft bone. This is the soft bone. So there will be a drop. Our drill will drop. Okay, this is the D1. When our drill will drop, this is the D1. Then what we'll do is we will continue the osteotomy, and again when will we reach the nasal floor, there will be a resistance. This is the R2 resistance. Okay, then we perforate it also, then there will be a drop. This is the second drop, the drop D2. So we have to see on the drills at what length there is a drop. Then we select the implant accordingly. Okay, I will demonstrate it to you. This model is visible.
Yes.
Okay, so what will happen is when I start drilling, this is the hard bone. Okay, so what is happening is I will feel a resistance. Then there will be a sudden drop. Okay, now what has happened is the drill has entered a soft bone. Now the bone is very soft. When I continue drilling further, there will again be a resistance felt. Okay, and there is now resistance. Now I have reached the base of the nasal floor. I will keep on drilling
Nasal
further.
floor, no resistance, doctor.
What are you saying?
Nasal floor, no resistance.
This is the nasal floor. Okay, then we will drill further.
Okay.
Okay, and our drill is now out. Our drill is now perforated. Okay, so we have to see at what depth our drill has perforated. There are markings. Okay, we will see at what depth our drill has perforated, and then the drill, we will see it on the scale. We can also see it on the scale, or there are markings on the drill also. So the drill has perforated at 23 mm. Okay, then what we'll do is we will take a 23 mm implant. So this is a Basal classic 23 mm implant. Okay.
Okay.
So now we'll do is we will load it onto the hand driver. This is the hand driver with the rotating mechanism. Okay, what we can do is when we are placing the implant, we can rest our hand against this side. So there will be no tilting of the driver. Right? And what we can do is we can load the implant, and then we will start screwing the implant in the osteotomy. First, when we are entering the first cortex, we will get very high torque. Okay, when all the threads are in the soft bone, the torque is gone. See, the implant is now free. It is spinnable by the fingers only. Then again, what will happen is we will start feeling the resistance. Now it's not spinning, right? Now we are going near the nasal floor. We keep on torquing the implant. We get very high torque, and what we see is the implant emerges in the nasal floor. Everyone can see the implant is visible here.
Yes.
Yeah, we can see.
So one thread of the implant should always be visible in the other cortex. You cannot see in the patient's nose. You just have to feel, because we have drilled and we know the second cortex is at 23 millimeters. So when we are placing a 23 millimeter implant, now we know the implant is engaging the secondary cortex. We can confirm it on an X-ray also. The tip of the implant should be actively engaging the bone. Okay, it's clear to everyone?
It's clear, but it can perforate the nasal mucosa.
Yeah, it can perforate.
It will be palpable on the floor.
No, not to the patient. Only 1 to 2 millimeters. The first thread of the implant should be out of the nasal cortex. Okay. And even if we rupture the membrane, the soft
Must
tissue will go over the
perforate.
implant.
What if we
Must
don't
perforate.
perforate?
The implant will fail. The implant will fail.
So the perforation is must.
For in basal implant, perforation is must.
For engagement, right?
That is a golden rule of basal implantology. It's called the golden rule of basal implantology, that the implant should always be engaging the secondary cortexes.
1 millimeter or 2 millimeter, right?
Only the first thread.
Only the first thread.
Okay, you can go beyond that. There is no problem, but the first thread should always be engaging the basal cortex.
Okay, okay.
As this is the
in compressive type. We also perforate.
No, in compressive we don't need to perforate.
Okay, thank you.
Okay. In compressive implants, if you want to perforate, then we also have a smooth surface compressive implants. Okay, its name is Tornado. You can see, I will share you on the screen. Okay.
Okay, okay.
So there is a smooth surface compressive implant also. So in which it's not surface treated. So you can perforate that implant, and that can be perforated.
Okay, okay. It is
But the rough surface implant, you don't. Okay. So what is the science behind the basal implant is only the threads of the implant are active. The remaining shaft has no threads.
No threads?
So no, the thread only at the apex.
Yeah.
The threads are only at the apex. So we don't take any kind of anchorage from the alveolar bone. We only take anchorage from the basal bone that engages these threads.
Okay.
Okay.
Okay. These threads should engage
Please, the
basal bone
camera
like
is
this.
not working. Camera is not working, sir.
It's working, sir. There's a problem with your connection. Everyone else is able to see.
Okay.
Okay.
You can rejoin the meeting.
Everything is okay, sir. Please go ahead.
Okay. Go ahead.
Go ahead, sir. Go ahead.
No.
Sir, I had a question. Sir, I wanted to ask when to note the length of an implant while drilling, when we touch the second cortex or after perforating the second cortex.
When we perforate a second cortex.
At that time, we have to note the length, right?
Yeah.
Sir?
Right.
Okay, sir. Thank you, sir. Maybe this was my question.
My presentation is visible.
Yes.
So why anchor in the basal cortex? What are the various advantages of anchoring the implant in the basal cortex?
Is it bendable?
Yeah, it's bendable up to 45 degrees, 50 degrees even. I will demonstrate the bending of the implant in the mandibular video.
Okay.
Okay, when we will be studying the mandible, I will be bending the implant. Okay.
Hello.
So, can you please mute your mics, everyone?
So can we
Yes.
more than two threads in a cortical plane?
Yes, doctor.
Hello.
Hello. Sir, please keep the question answers for the last. Okay. Let me complete the presentation
Go
because
ahead,
we
sir.
had a
Go ahead.
well, we had a 2 hour window. So let me complete the presentation first. All the Q&A will be held in the last. You please note down the questions, okay, and write it on some paper and ask me in the end. If there is any trouble in understanding my language, then you can ask me. I can repeat it, but the queries will be held in the last. So, what are the advantages of engaging the implant in the basal bone? It is almost always present because it's the bone that is left after everything is resolved. Okay, so it's almost always present, even in the case of highly resolved cases. It is highly mineralized bone and it gives good anchorage and torque, allowing for the immediate loading. Because it is highly mineralized, it is very less prone to resorption. Hence, the implants can last for very long. And because of dense structure, we get very high torque, and the implants can be immediate loaded. It is far from the surgical entry site. Like I told you, the implant is entered from the alveolar bone and is engaged in the nasal cortical floor. The threads are only in the basal bone. So it is very less prone to the infection since it's very distant from the portal of entry of the infection. The implant, which takes support from the basal bone, often excellent long-lasting solution for tooth loss. Load-bearing capacity of the basal cortical is many times higher than those of the spongy cancellous bone. Because of dense structure, the load-bearing capacity is very high, and the bone does not fracture even if we load the implants immediately, and there is lot of occlusal forces. Then also the bone will not resorb or fracture. What are the techniques in basal implantology in the maxilla? We will do the maxilla first, then we will move on to the mandible. The bending of the implant will be displayed in the mandible, right? So what are the basal cortexes in the maxilla? We have read, anyone wants to repeat these cortexes?
Please, PowerPoint note. Yes.
Any question?
No, no, sir. No.
Okay, these are same cortexes I displayed on the model. Okay, you can take the screenshot of this slide if you want to. It will be for your help in the future when you are studying the basal implantology in depth. So you can take the screenshot. It's a very important slide. So this is a nasal cortical anchorage. I displayed it, right? Anyone has any doubt in nasal cortical anchorage?
No, sir.
So the selection of implant according to the situation, like I told you, in basal implantology, we always select the implant according to the situation. We don't modify the bone to fit in the implant. So when we are going for nasal cortical anchorage in the anterior maxilla, the preferred implant is the basal varios. Okay, we can also use a basal classic or basal vampire, but my choice of implant is the basal varios. Why basal varios? Because basal varios have two kinds of threads. Can you please mute your mic, everyone? There is disturbance coming. Okay, fine. I muted them myself. So various implant have two kinds of threads. There are cortical threads at the apex. Everyone can see that. And there are compressive threads just behind that. So what is the advantage? These threads that these actively engage the nasal cortical floor. These are cortical threads, and there is spongy cancellous bone. So we also take advantage of that. And this implant, because of the compressive nature, anchors the implant very well, and we get very high torque in the spongy bone also. So overall, it's bifocal anchorage. We take the advantage of the nasal cortical as well as the cancellous bone. So that's why in the maxillary anterior region, the preferred implant is the basal varios. Any doubt?
No, sir.
You anyone wants to see the enlarged 3D printed model of basal varios on my tabletop?
Yes, sir. Yes.
Okay, just coming up.
Yes.
So this is compressive and basal.
This is compressive and basal, right? So you get bifocal advantage. You get the best of both the worlds.
Okay.
Doctor, please, what's the difference between basal implant and bicortical implant?
Sir, basically, bicortical implant is the wrong terminology. Okay, it's the earlier terminology because please mute your mic.
आमच्याच घरात काय ती मांडणं बाकी आता तुम्ही काय तिघं त्याच्यावरती दोघं टाकणार.
Okay, so basically, what does the and everyone can see my tabletop. My tabletop is visible. So bicortical means taking anchorage from both the cortexes. So there is no implant that take anchorage from both the cortexes, right? So that new terminology is the basal cortical implants. It's not the bicortical, that's wrong. It's the basal cortical because the implant only have threads at the apex. So what it does is it engages the basal bone only. Here we can see, like I told you, we start drilling. This is the alveolar ridge. This is the nasal floor. The implant engages like this. Okay, so the cortical threads engage the basal bone. Cancellous threads engage the cancellous bone by the action of compression. The shaft is passive. It's a passive shaft. It does not have any threads. So it does not take anchorage from the first cortex. The first cortex is totally passive. Why? Because first cortex is highly prone to resorption. If we take anchorage from first cortex and there is some peri-implantitis or some other problem, there will be resorption. The threads will get exposed and there will be peri-implantitis. So what we do is we don't place threads at the first cortex. So in this case, there is a smooth shaft only, hence no peri-implantitis is seen. It's clear to everyone? Dr. Rahul, Dr. Ali.
Gangadi sir, I have muted everyone.
Okay, right.
We can have the question answered at the end.
Perfect.
Yeah.
Let me get back to the presentation again. Basically, I have to switch on both the screens simultaneously. So there is some delay in between. So the preferred implant in the nasal cortical anchorage is the basal varios. The surgical demo and anyone needs, I have shown you in the previous slide how the nasal cortical anchorage is done. Does anyone wants to repeat the demonstration? You can raise your hands if anyone wants to. Ma'am, please unmute Dr. Ali. He wants to say something.
Yes, I'm doing. He can say.
You have a mute voice. Okay, now it's okay.
Please repeat the surgical technique.
Okay. My tabletop is visible.
Yeah, the demo is surgical techniques and demo. Is not visible. Now it's visible. Now
It's visible now.
Yeah.
Actually, I have to rotate it to get into portrait mode. So like I told you, the concept of R1, D1, R2, D2, right? There is a, when we start drilling, okay, I will remove the implant from here. So the patient is lying on a chair in this position, right? So what we'll do is we will start drilling. Since when we perforate a gingiva, this is a hard bone. Here there will be a resistance, that is the R1 resistance, okay? And when we perforate the first cortex, we will enter in the soft bone, right? There will be a drop, sudden drop of the drill will be there. The bone will become very soft, okay? After that,
Okay.
we will continue drilling and there will be a resistance again. Now there will be resistance again when the drill reaches the floor of the nasal cavity. Then we have to continue the drilling. It will perforate and emerge from the floor of the nasal cavity. We will see the drill coming out from this side. At this point, we will see at what depth there was a perforation. There are markings on the drill, okay, for the implants, and we can select the implant accordingly. Or if we are new to this, what we can do is we can take the help of the scale. We can see like on the fifth mark there was a perforation. We will go on to the scale, put it inside the fifth mark. We will see the implant is a 23 millimeter implant. Then we will open the 23 millimeter implant packaging, load the implant on the driver, and start placing the implant in the prepared osteotomy. Okay.
Okay. What's the torque?
What's the torque? We get approximately 60 to 70 NCM torque.
Newton, 60 Newton?
60 newtons approximately.
It's not harm for the bone?
No. The basal cortex, it's very highly dense bone. Okay. In the alveolar bone, this is wrong. But when we use the basal bone, it's not wrong. Basal bone can survive torque up to 80 NCM.
80.
80.
Okay. Very
Okay,
nice.
doctor, one question, please.
Yeah, please.
What are the risks and complications associated with basal implant?
Risk and complications, basically when we are dealing in the pterygoid area, okay, and when we are dealing in the mandibular posterior region and anterior region, there are risk of damaging the anatomical structures, right? Because we have to be very careful. Basal implant is very technique sensitive. When we are performing the lingual cortical engagement, I will show you these complications will be covered when these techniques come now. Everything will be covered. These are in the slideshow, so I will come back to you when the time for this comes.
Okay, thank you.
Any problem with the understanding of the basal cortical or nasal cortical anchorage? Anyone has any doubt? Okay, repeat after me. The golden rule of basal implantology is to engage the secondary cortex. The second cortex has to be engaged every time. That's the golden rule of basal implantology.
Doctor, please, if we can replace 1-1 or 2-1 by basal implant, 23, when we can put the fixed procedures?
On the same day.
Immediate load.
Immediate load.
Okay, thank you.
I'm going back to the presentation. We will have all the doubts in the end now, because it's already very late. A lot of people are leaving now. So let me complete the presentation, and those who are with me, I will clear all your doubts. Okay, I won't go anywhere without clearing your doubts. I will be here till the end. So anyone who has any doubts, please keep on noting it down and I will answer it in the end. And this is the alveolar bypass technique. When we have very narrow knife edge, as you can see, and everyone is able to appreciate, there is a knife edge ridge. So no place to place the implant. There is no enough width present. So in basal implant, because the shaft is smooth surface, okay, it does not need to be in the bone. It can be in the soft tissue as well. There are no threads on the shaft. The shaft can be freely placed in the soft tissue, and because it's smooth surface, grade 4 titanium, there will be muco integration. The mucous membrane will integrate with the with the titanium surface. Okay, it's clear to everyone. This is the alveolar bypass technique.
Yes,
Yeah.
We can
alveolar
place the
bypass.
implant on the palatal aspect. Anyone wants to see this technique?
Yes.
Yes, please.
Yes, please.
Please, I would like to ask some one question. Please, I would like to ask you if that it is safely to the basal implant to pass the maxillary sinus already and penetrate the mucous membrane without bleeding or make anything to the maxillary sinus?
Gagandeep, so you on mute.
My drill is visible. So we start drilling on the palatal aspect. Okay, we bypass the alveolar bone. Now we will place the implant on this side and we can bypass the alveolar bone. So this is the alveolar bypass technique.
So it is simply you know that the usual implant we make sinus lifting, but in this case we can use safely the basal implant without without any complication with the nasal sinus.
Exactly. We have a various X implant that is meant for engaging the floor of the sinus. It will come in the following techniques. We have an implant for the sinus area as well. Because in our philosophy, we have developed an implant for every kind of clinical scenario. So we don't modify the bone. Whatever kind of bone is given to us, we place an implant in that only. Right? So we
Thank
have an
you.
implant for every kind of situation.
Thank you.
Okay, the preferred implant for the alveolar bypass technique is the basal various implant. Basal various and basal various only.
Doctor,
I have demonstrated the surgical
Doctor,
technique.
how number in the basal implant in the anterior maxilla?
Your question was not, ma'am. Can we please keep the questions for the last?
How number? How number the basal implant in the anterior maxilla?
For full mouth?
Yes, for mouth. For mouth.
I will come back to it in the end. Okay. You please remind me in the end. I
Okay.
will answer the question in the last. Let
doctor,
me wind
please.
up the presentation very quickly. So we
Doctor,
can also engage the anterior sinus wall.
Doctor, please, can you explain the bus nerve pass technique in lower molar area?
It will come in the mandible. Now I am in the maxilla yet. Okay.
In mandible. Mandible.
In mandible. Okay. It is
Yes.
coming. It is coming.
6 to
Just
7
wait
area.
5-10 minutes. It's coming.
Okay.
So in the there is also anterior sinus wall engagement. So with the there is a vampire implant. With this, we can engage the anterior wall of the sinus. Everyone is able to understand which implant it is? Can someone repeat? Can someone repeat the name of the implant?
Basal vampire.
Basal vampire, yeah. Okay. So this
What is the difference of usage of them, the vampire and various?
I will have to change to my screen. Let me turn on my camera. I will show you on the implant only. So this is the varios. Everyone can see that? Yeah.
Not see.
It's visible?
Yes. I can see.
So this is the varios. Okay. So it has two different kinds of threads. Okay. Cortical thread at the apex and then cancellous threads, compressive threads just behind it. Yeah. Two threads, but both are at different positions. Okay.
Yes.
Whereas in vampire, both the threads are alternating. It has two kinds of threads. These are the cortical threads, and in between there are compression threads. Everyone can see? There are two kinds of threads. Let me zoom in on it. Now everyone can see?
I mean, where we use this and where we use this? Difference.
This is meant where the second cortex is not very well differentiated. Like in the maxillary sinus area, the floor and the anterior wall and the posterior wall, these are not very hard cortexes. These are soft cortex, right? Like in the nasal cortex, this is a very hard cortex. The bone is very dense. So here we will use varios. Why? Because varios has cortical threads at the apex. So this will engage the nasal floor. When in the posterior maxilla, the differentiation is not much. The floor of the sinus, the anterior wall of the sinus, and the posterior wall of the sinus are not very well mineralized. So in this case, we have developed this kind of implant in which both the threads run alternatingly. There is a cortical thread, then there is a compression thread, then again a cortical thread, then again a compression thread. So in the softer kind of bone situation, when the bone is soft, like D3, D4 bone, we go with the vampire implant. It's clear now?
Not very clear.
For D2, D3 bones.
Yes, clear.
So D3, D4 bone, we go with the vampire because it's the most high torquing implant in the industry. All the implants that I'm showing you, all these are patented implant designs. These are all patented implant designs. The pros, the vampire, the varios, these are all patented designs. So this is the highest torquing implant in this industry. So if you try placing it in the D1 or D2 bone, the implant will fracture or the bone will fracture. So this is particularly suited for softer bones. When we encounter D3, D4 kind of bone, we go with the vampire implant. Otherwise, in normal situations, we go with the various implant. Because in this case, the cortical threads are at the apex, no compression threads are at the apex. The compression threads are radially to the apical threads. It's clear?
So vampire in D3 and D4 area, right?
Yeah, right.
Okay, thank you. And D1, D2
Vampire
area,
in D3.
various, right? Basal various.
Various. So I'll continue the
D1,
slideshow now.
D2 various.
D1, D2 various, D3, D4 vampire.
Okay. Can you write them please on the board?
Sir,
So
we will
can.
continue to this in the end. There are a lot of slides left, so let me please complete first. I will answer every question
Sorry,
in the
sir.
end. Okay, you keep on
Sorry,
noting
sir.
the questions. Okay, you keep take a page. You start writing the question. I will answer every question in the end. I promise to you.
Thank you.
Okay, I will not leave before answering every question.
Thank you, sir. Thank you, sir.
Okay, okay, thank you.
So, like I told you, in the anterior maxilla, posterior maxilla, when engaging the anterior sinus wall, the preferred implants are the basal varios and the basal vampire. There was a question regarding the sinus floor engagement. So we have an implant for that also. This is the varios X implant. So the diameter of this implant is minimum 5.5 to 9 millimeters. This is the diameter. Okay, we have very wide diameter available. So these are particularly suited when we want to engage the floor of the sinus, because what we see is in the floor of the sinus, the height is less, right? The height is very less, but the width is very high. We get a lot of width here, but the height is very low. Everyone agree?
Diameter, repeat please.
5.5 to 9 millimeters. This is the various X. So what the problem is encountered is we have the width of the bone, but we don't have the height of the bone. So we need a surface area to engage. So what we have done is we have developed the implant that are short, but that are wide. I will show you the model, okay? This is the various X. It's clear, visible to everyone. You can see only few threads, only 2 to 3 threads, 4 threads. And we have the cortical threads and the compressive threads running in between. These are the compressive threads. Cortical threads and the compressive threads. Same the various design, but very large diameter. So this implant is suited for engaging the sinus floor. Clear to everyone? Okay.
The picture maybe is not shown.
My camera is visible.
The picture maybe. No, it's not visible.
My camera visible now? Is my camera visible?
Visible.
Visible now? So there is
Yes,
problem.
yes.
Maybe the connection.
No, no.
Connection maybe.
Okay. So this is the various X. Anyone want to repeat the name of the implant? Anyone can please repeat the name of the implant?
Basal classic, basal various, basal vampire.
Right. Very good. You should remember the name of these implants now. When you are ordering, it will be very easy for you to order from our side. We also have a detailed catalog. If anyone wants to see, we can also share that to you.
Please share. Please.
So this is the various X implant. Vampire we have talked about. Okay, there are two parallel threads running. One are the cortical threads and other are the compressive threads in between that. So this is the vampire implant. We have talked about it before. This is the patented highest torquing implant in the world. You cannot get more torque than this. Just hold on a minute. I have called. Hello. सर मीटिंग में, आई विल कॉल यू बैक थोड़ी देर बाद ना. नहीं, मैं अभी नहीं, मैं मीटिंग में था, मैं बाद में बात करता हूँ. Okay, so we have talked about the vampire. Any doubt with the vampire or varios X? So in the pterygoid implant, we have a tornado implant. This is a compressive implant, but a smooth surface compressive implant. In the rough surface compressive implant, we cannot perforate a second cortex. But in this design, the tornado implant, we can perforate a second cortex. So this implant is particularly made for the pterygoid area. Okay. So the choice of implant is the tornado implant. You can also use a varios implant in this scenario, but you have to use two varios. Okay, if you are using varios, then you do double pterygoid implant, not single pterygoid. But when we are going with the tornado implant, only single implant is recommended.
Huh?
Okay.
Hello. Hey, look
If
to you.
tornado, single is enough, right?
Right.
If you
Single
use
is enough.
various, two.
Various two. Two, right. There are some accessory sites also. Okay, these are the lateral nasal wall, palatal bone, or mid palatal engagement. So there are some things to be noted. These are only load dispersing sites. These are not load bearing sites. Okay, why we do is we want to reduce the jumping distance between the implants. Sometimes there is a lot of sinus pneumatization. Okay, so the anterior implant is in the canine region, posterior implant is in the pterygoid bone. So the distance between the two implants is very high. So there is a chance that the prosthesis might fracture under loading. So to reduce the jumping distance between the implant, we place the implant in these areas. Otherwise, these implants cannot be used as a standalone implant, not to be used as standalone implants. Okay, these are not standalone implants. These are only to be reduce the inter-implant distance. Clear to everyone?
Okay.
So one is the
Not
nasal wall engagement. Sometimes what happens is the height of the bone below the maxillary sinus is very less. So we cannot place an implant. Even a various implant X cannot be placed. So what we can do is we can engage the implant in the lateral nasal wall. As we can appreciate, the implant is placed in the lateral nasal wall. Everyone can see?
Yes, we can see.
So the choice of implant is either basal tornado or the basal varios. There is also a technique in which we can engage the palatal bone like this. We start the osteotomy very laterally towards the palatal bone and engage the palatal bone directly. So here the choice of implant is the basal classic. Because the bone is very less, if we use the various implant, the bone is very hard, but the diameter, the thickness of the bone is very low. So what happens is if we use the various implant or any other implant, the bone will fracture. So we have a low profile implant for these kind of cases. This is a basal classic, very low torquing implant. So in this case, because the bone density is very high, we can use the basal classic. Only few threads, no secondary thread, single thread design only. This is our only implant that comes with a single thread design to reduce the torque in this kind of situation when the bone is very narrow. Okay, clear to everyone?
Cannot we use the Basel Classic on all cases?
No, we cannot. We should not. Actually, the problem is that. Can you please mute your mic? I will explain it to you.
Okay.
I will switch on to my tabletop.
Sir, can you please explain the pterygoid implant placement?
What, sir?
Can you please explain the pterygoid implant placement procedure?
Sir, actually, I want to finish the presentation first. I will explain everything in the end. Okay. I'm limiting some questions now. I will explain everything. So what happens is when we are using the classic design now, it's visible. So what happens is this is the basal cortex. This is the first cortex. When the density of this bone is low, okay, so sometimes the basal cortex may be D1, it may be D2, it may be D3, it may be D4, right? So when we are using classic design, when the bone is D1 or D2, then we have to go with the 3.6 mm diameter. If the bone density is D3, then we have to go with the 4.5 mm diameter. If the bone density is D4, we have to go with the 5 mm diameter in classic, right?
Okay.
In various, what happens is because we have two different kinds of threads, the core diameter here is very narrow in the apex, then the core diameter increases. So the same implant acts as a 4.5 and a 5 mm implant. Sometimes when the bone density is D1 or D2, the implant will get torque in this area. Okay, only one thread will engage and the implant will be torqued. You don't need further torquing, right? When the bone density is D2, you have to engage the implant a little bit further because the core diameter increases, the implant will engage. If the bone density is D3, you can engage the implant a little bit further. If the bone density is D4, you have to engage the implant a little bit further. In classic implant, what happens is you place the implant, you don't get the torque, you remove the implant, you place the 4.5 mm implant, this implant is wasted. Right? Sometimes 4.5 also does not engage. Then you go with the 5 mm implant. So you have wasted two implants for a single site. So this is a hit and trial. Right? But with the varios, we always get a predictable result. Only a single diameter implant will suffice any bone quality. So that's why I recommend using basal varios. It's a very good implant.
All quality bone can be used.
Or quality bone. I only in my inventory, I am writing only 3.6 mm basal varios. Only. I don't have any other diameter of basal varios. It is not required. Okay.
Sir, can you please repeat it again, sir?
Ma'am, in the end, what you want to? What didn't you understand? Hello. So I am continuing. So what are the techniques in the mandibular basal implantology? There are primary cortexes in the mandible as well as the accessory cortexes. Can you please mute your mic, please? So the primary cortexes are the base of the mandible and the buccal cortical engagement, lingual cortical engagement, and the body of the mandible in the interforamina region. Okay, the accessory cortex site is the base of the mandible in the posterior mandible region. This is called the nerve bypass. Okay, when we engage the lingual cortical, it is called the lingual cortical engagement. When we engage the base of the mandible in the posterior mandible, it is called the nerve bypass technique. Clear to everyone?
Okay.
Yes.
clear.
So in the interforamina region, we have two techniques. One is engaging the body of the mandible. Second is engaging or passively resting the implant on the base of the mandible. In the mandible anterior region or posterior region, we never perforate the base of the mandible. The base of the mandible should never be perforated. Got it? This should not be perforated.
Yes.
This is the only place in the mandible because
So where we know.
I didn't hear your question. I'm coming to it. I'm coming to it. So what happens is if we perforate the basal cortex, so what happens is there is the pathological weakening of the mandible and the mandible might fracture. Okay. So there are two techniques in the interforamina region between the two foramens. It's clear to everyone. Everyone knows the interforamina region. Any doubts in the interforamina region? Okay,
No.
so there are two techniques. If we have very high density bone, if we have D1 or D2 bone, what we can do is we can place the implant directly in the body of the mandible. We don't go till the apex because the bone density is very good. This bone in between the body of the mandible, there is no cancellous bone in mandible because it's very hard bone. So this bone acts as the basal bone in itself, right? So we can engage the implant here only, right? But when the bone density is very low, there is cancellous bone present, there is D3 or D4 bone present. What we do is we go till the base of the mandible, but not perforating it. Not perforating it. The implant is passively resting on the base of the mandible. Got it? The implant is passively resting on the base of the mandible, not actively engaging it. So the choice of implant is basal classic. In case very dense bone, it's D0 bone. It's like rock hard, patthar hai bilkul, stone. Then we need low torque implants. Then we go with the basal classic 3.6 mm diameter in D0 bone, just like stone bone. In D3, D4, any kind of bone, like I told you, we go with the various implant. Or we can go with the tornado implant also in the mandible anterior region. Because tornado implant can be rested on the base of the mandible also. So it will take advantage of the soft bone. Sometimes, like I show you in this slide, the bone here is very soft. So the tornado implant passively rest on the base of the mandible while compressing the spongy bone. So this implant can also be used. Okay, anyone can repeat in mandible anterior region what implants can be used? Someone please name the implant.
Classic.
Tornado implant.
Basal classic and basal varios and what is the third one?
Tornado.
Tornado. Yeah, very nice.
Doctor,
In the
here only three implants used in the mandible, tornado and Basal.
Yeah.
Classic
And various, not vampire.
and varies only.
Only.
Okay.
Okay. So in the posterior mandible, that is the region behind the mental foramen, we have again two techniques. One is the lingual cortical engagement. It can be reversed similar to the buccal cortical engagement. Both are the same technique. That is, these are the supranerval procedure. That is, the implant is above the nerve all the time. Second is the nerve bypass technique. So these are two techniques are one technique only. There are two ways, but the technique is one. Second technique is the nerve bypass technique. Okay. So the lingual cortical engagement I will demonstrate to you on the bone model. Want to see on the bone model?
Yes,
Yes, sir.
please. Yes.
You are liking the lecture?
Yes, sir.
Yes, of course.
Any problem understanding my language?
No, sir.
Let me turn to portrait mode. It's not turning. Right. हो गया. Done. So which technique you want to see first? Any particular
Lingual
technique you
cortical
want to?
engagement.
Lingual cortical engagement. Okay. So it's a very simple technique. First thing first, lingual cortical engagement. Lingual cortical engagement can only be done distal to the first molar. Okay, like this is the mandible. This is the first premolar. This is the second premolar. Pardon my drawing skills are very poor. This is the
Sir,
first molar.
we are not seeing your drawings.
My camera is visible, everyone?
Yes,
No.
visible.
Yes,
Yes.
sir. Yes, sir.
So there is problem with your connection only. So the only landmark for this implant is the mylohyoid ridge. Can you repeat mylohyoid ridge?
Mylohyoid ridge.
Mylohyoid ridge.
Okay, that's a landmark. So mylohyoid ridge is palpable up till the distal root of the first molar only. So this implant can be done from the distal root of the first molar to the third molar in this region only. Okay.
Okay.
In this region, it's not doable. In the mesial root, first premolar, second premolar, it's not doable. Only doable in the from the distal root of the first molar, second molar only. Because in the first molar mesial root region, we cannot palpate the mylohyoid ridge. Okay, so how we proceed is we palpate the mylohyoid ridge first. It's very prominent when we put the finger inside the patient's mouth on lingual side. We can easily palpate the mylohyoid ridge. It's a basal bone. It's never resorbed. Even in most resorbed cases, it's always present. It's the attachment point for the mylohyoid muscle. Which muscle?
Mylohyoid muscle.
Myeloid muscle.
Right. So what, and the nerve is always present below the mylohyoid ridge. This is a point to be noted. The nerve, please mute your mic. The nerve is always present below the mylohyoid ridge. not above it. So this is a blind procedure with no chance of nerve injury. So in the area, we decide we have to place the implant. Suppose I want to place the implant in this area, right? So what I will do is I will place my finger over here and place the drill over here and aim for my finger. I want to aim towards my finger. When I palpate the drill, here I will stop drilling. We don't perforate too deep. Okay, there are lingual arteries. So when I feel the tip of the drill, I stop. Right? Clear to everyone?
Yes.
Please again, when
Yes.
we reach where? How
We
can we
have to
know that?
place the finger on the mylohyoid ridge. Okay. Start drilling from this side. When I feel the tip of the drill coming out on my finger.
And sir, if the myloid ridge is prominent and if it is coming up to first molar, then
What, sir?
So you penetrate the mylohyoid.
Yeah, like this. We can see the drill coming out. But we
we
don't
should
go
not
very deep.
perforate.
We
We
don't
should not perforate.
we don't go like this. This is not to be done. Not. Okay. Only perforate only when you feel the tip. Stop. Okay.
Yeah.
Okay.
When we feel it, we stop.
You stop. Right.
Okay. If there is a short bone, sir.
Right.
And we could not know where is the nerve actually.
Sir, the nerve is always below the mylohyoid ridge. For sure. There are numerous papers on this. The nerve is always below the mylohyoid ridge.
In 1 or 2 millimeters or?
2 to 3 minutes. Sir, basically what happens is my drawing is visible.
Yeah.
So I am drawing on the patient's left side. So the anatomy will be something like this is the mylohyoid ridge. This is the level of the mylohyoid ridge. Okay, the nerve is always below the mylohyoid ridge. Okay, so when we are placing the implants, we are always aiming laterally. So the nerve is, even in the height, the nerve may not be far away, but the implant is very lateral to it. The implant is very lateral to it.
Okay.
Got it?
Got it, sir.
So then we place the implant in this manner, and we will keep a finger on this side. When the tip of the implant starts coming out, we stop. The tip is out. It's visible.
Hey sir, where is
Yes.
the mylohyoid muscle in here?
The tip is out. It's shining, right?
Yeah.
Now what we do is we
Doctor,
bend the
please.
implant.
Doctor, please. The point of entry from buccal side, how many milli from the alveolar crest?
Sir, the implant should be at 45-degree angle.
From the alveolar crest, how many milli?
No,
Milli or
sir.
more?
No. It's not in millimeters. You have to aim for your finger. Okay. You place the finger below the mylohyoid ridge, then you aim for the finger.
Yes, by the
Whatever
angle,
angle it may come.
45 angle.
Approximately 45-degree angle.
Okay.
Okay, you have to basically aim for the finger. That the point of exit determines the point of entry.
Sir, then how to detect the implant?
Your question was not clear.
To detect the size of the implant further, sir.
Ma'am, whenever there is the perforation, we see what is the depth at which there was perforation. Okay, we see the drill markings, then we correspond it to the implant size.
Thank you, sir.
Usually, sir, which size of implant goes away mostly?
Sir, 12, 14.
Okay.
Okay.
Okay, fine.
So then what we do is,
3.6.
this is mostly
3.6
mostly 3.6 classic,
classic.
because this is very hard bone. Myelohide ridge is very dense bone because it's a muscle connection, so the density is very high. So there are two advantages of doing the lingual cortical engagement. Okay, first advantage is the nerve is always below the myelohide ridge. What's the second advantage? Can anyone answer? Can anyone
Less
answer?
chance of There is a less chance of injury to the nerve. It
No.
is
That too I have said. That too I have said. What a second advantage.
Highly cortical mineralized bone of myeloid ridge.
That's to every basal bone.
Tongue cannot be reached there, sir.
Huh?
there is
Tongue cannot be reached there.
Exactly. Dr. Jaideep, you were right. So what happens is there is a myelohide muscle over this. Okay. So the myelohide is covering this area. So the implant tip will be below the myelohide muscle. So patient will not be able to feel the implant over here. So that's the beauty of lingual cortical engagement. Okay. Similar thing if we do from the other side. If the same thing we do from the other side, okay, what we can do is we can start lingually and come out buccally. Similar manner. That is called the buccal cortical engagement. Right? Clear to everyone?
No. What's buccal cortical engagement?
You understood
Buckle
lingual
or
cortical
lingual.
engagement? You got the lingual cortical engagement?
Yeah.
So when we start drilling on the lingual side, put our finger buccally, then aim for the buccal side.
Drilling lingually.
Start drilling lingually to the buccal side.
Yeah. Okay.
So it's a rescue procedure. Sometimes what happens is you basically the osteotomy is sometimes destroyed because the doctor is not doing the procedure properly. Sometimes there is a trouble and you are not able to engage the lingual cortical engagement. So what you can do is without wasting the site, you can place the drill lingually, start aiming buccally. So you will get the buccal cortical engagement. I will
There
demonstrate.
is no nerve damage.
Is there any landmarks for that buccal cortical
No.
engagement?
So that is why it's not a preferred technique. The preferred technique is the lingual cortical engagement only. The buccal cortical engagement can be done as a rescue procedure.
Okay.
Getting my point? It's a
Actually,
rescue
True,
procedure.
true.
It's more risky because you don't have any landmark over there.
No risk.
So there is a chance if you basically if you don't begin the osteotomy on the right side, your drill may pass through the nerve, right century to the
That's
nerve.
it.
That is, it's not a preferred technique. The preferred technique is the lingual cortical engagement. Buccal cortical engagement can be done,
Yeah.
cannot be done.
Buckle or lingual. Yeah.
Lingual is preferred.
Okay.
Okay. So everyone gives a thumbs up if everyone is liking the video.
Sir, but sir, buccal cortical engagement, what are the cases where we prefer to go with buccal cortical engagement? We get to know about lingual cortical engagement, but
Please,
where
everyone, please give a thumbs up first. If you are liking the lecture, give a thumbs up. Right, a lot of thumbs up are coming. So, sir, what happens is we always go with the lingual cortical engagement first. Okay, if due to some reasons, because some operator fault, the lingual cortical engagement is not possible, or the osteotomy is destroyed, or the implant may have failed in the lingual cortical engagement, then we employ the buccal cortical engagement as a rescue procedure.
Okay.
Okay, it's a
So
rescue procedure. Should
okay.
it basically it's not the first choice of action. If it's the plan B. Okay, it's a new I think it's a new word. It's the plan B. Buccal cortical engagement plan B. Right?
Sir, like how many implants
Yeah,
will be
plan B.
needed to replace the single molar, sir?
Sir, to replace a single molar, we place two implants.
That is both
One
are
for each
Implant.
lingual.
root. One for each
Second
root.
and first molar.
Yeah. There is an important point to be noted here. When doing a single molar, two implants.
So that is two implants that are lingual or buccal also, sir?
Sir, preferably lingual. In the first molar, what I used to do is I place a compressive implant in the mesial
Okay.
and a buccal cortical
And distal.
engagement in the distal root.
So both will be lingual, not buccal.
Both, no. The compressive will be straight.
Compressive will be straight. There's no perforation for that.
No perforation for that.
Okay.
Okay, doctors. يعني implant بالroot.
Ma'am, what?
One implant بالroot.
For lingual cortical
No. It's
engagement?
not per root. So, sir, usually if it's first molar and second molar, like what do you prefer, sir, for this?
Okay.
Sir, I just missed my point. So when we are replacing two molars, okay, two
Yeah.
molars, then three implants only, not four implants.
Okay, three implants in the sense like where all, sir?
Three implant only.
Okay, three implants only. Like this is the
Yeah.
first molar, this is the second molar. Okay,
And
so one
immediate
implant in the
loading.
mesial root, one implant in the center, one implant on the distal root.
Okay.
So what I
Immediate
heard is like
loading,
we
right,
need a
sir?
tripod effect to replace first and the second molar is what I heard is.
What, sir?
The tripod or bipod effect should be there. That then only it will be good for
Sir,
covering the implants. If you
this is the tripod.
so you mean to say like three implants are enough for two molars? Huh?
Yeah, you can place four implants, but this is the minimum number of implants. You cannot
Okay,
place
sir.
two molar on two implants. These three implants are the preferred one.
So usually,
And
if you see
immediate
like if
loading,
only
right, sir?
the
Immediate
first molar
loading.
and second molar is missing,
Hmm?
there's no much space to put three implants also, sir, in this.
Sir, if one tooth is missing, you can always place. Sir, you used a narrow diameter implant.
Narrow diameter. Okay.
I will show you the case. I have the OPG. Just wait
Okay,
on a
sir.
minute.
Yeah.
Doctor,
Sir, in some cases, there is
after
a
we get
myloid
It's
ridge
visible.
is not prominent. Okay,
Two compressive implants.
there are certain cases where myloid ridge is not prominent, and both the walls are parallel to each other.
Those
Then
are
what implant to
compressive.
be preferred in that case?
These are compressive implants, right? Both are
These both
compressive.
are compressive.
Yeah.
So
I had very large height, so I placed both compressive. It was a
how
healed
do we
area.
decide the heights for this compressive implants?
OPG.
Okay, from OPG you can just judge like what will be the height of the implants.
Yeah.
And which
I get
material is this
OPG
for the
that has the
processing?
exact scale mentioned. Okay, I get OPG. So there is an exact scale
Okay.
mentioned with a magnification defect also.
Sir, this is a
Okay.
PFM crown or is a metal acrylic?
PFM crown, sir. Clear, everyone?
Yes.
I have a doubt actually.
Doctor,
Sir,
after
if
we
the
put
first molar
the
is
lingual,
hexagonal,
after
we
we
have
put,
to replace it.
doctor,
How to do, sir?
What, sir?
Doctor, no problem. To implant first molar.
Uh,
please,
uh,
doctor.
yeah,
Sir, like actually, like what
just
happened?
hold on a minute, please.
I had a
Only three,
recent.
four slides are left. Can I finish the slides first?
Yes, sir. Yes, sir. Please go
Doctor,
ahead.
Okay, then we
doctor,
can
Yes, sir.
continue.
Go ahead, sir.
after we put,
Go ahead. Go ahead.
So there is also a nerve bypass technique.
after we put the
Sir,
cortical,
afterwards, at the end,
Sir.
doctor,
questions at the
after
end
we put,
now. Sir, questions in the end, please. Sir, pardon me.
Fine,
Questions in
fine,
the
fine.
end.
Fine.
So there is a nerve bypass technique. So this can be done distal to the tooth number 7. When we are doing the full mouth implant cases, so what we can do is we can
بالكلام مباشر ما بيعرفش يتكلم انجلش.
everyone please
خد
mute your
نقطة
mic.
جيب الحزام.
Please mute your mic, everyone. It's visible. So, like I told you, that was a lingual cortical engagement and the buccal cortical engagement. There is also a procedure that is called as the nerve bypass, in which what we do is we place the implant next to the nerve. Okay.
Okay.
So you need a CBCT for this case. Sometimes what happens is there is nerve dehiscence. The nerve is at the level of the alveolar bone. You have seen the cases now? Please mute your mic, Dr. Mahmood.
وفيها ايه؟
Dr. Mahmood. Okay. Dr. Jadi, please mute your mic. There is disturbance coming. So we have to use a CBCT for this. When we do the OPG, we see the nerve is at the crestal level. So there is no place to lingual cortical, buccal cortical engagement. If we try this, there is a risk to the nerve. Right? So in these cases, we go with the nerve bypass. In very highly resolved cases only. And in the resolved cases, it is very simple to do the bypass. Once you have a CBCT done, you know the exact position of the nerve, right? So you can place the implant just right beside the nerve without damaging the nerve. Okay, clear? This is only when there is nerve dehiscence, the nerve is at the crestal level. Then you will go with the nerve bypass technique.
Okay.
The preferred implant is the Basal Classic and the Basal Tornado. Why? Because when we are placing the implant right next to the nerve, we don't want any bony compressions compressing the nerve. Right? Sometimes what may happen is we place the implant has not perforated the nerve. The drill has went right beside the nerve. But what happens is because of the pressure, the nerve compresses and there may be paresthesia. Because the classic has a very low profile thread. So it does not give any lateral compression to the nerve. And one more thing, the implant is rested on the base of the mandible in this case, not the body. So you have to drill to the base, not perforating the base. You will drill to the base, not perforating. Okay, the implant sits passively on the base of the mandible.
Sir,
Right?
can we use compressive implants in nerve bypassing?
No, rough surface implants are prohibited. You can use a smooth surface compressive implant. Okay, you can use a tornado. Because why? Because tornado we have a 3 millimeter diameter as well. If you want to use a compressive implant, you have to use a smooth surface tornado, not rough surface. Why? Because sometimes when we are placing the implant right next to the nerve, because this is a rough surface, when we are screwing in the implant, the rough surface might grind off the nerve. Okay, there is a nerve laceration. Like we fall on the road, we rub our knees now because the road is rough, the knees are lacerated. So the rough surface of the implant can cause laceration on the surface of the nerve and may cause demyelinization of the nerve, which does not lead to paresthesia, but is a very painful condition for the patient. Okay. So if we want to use a compressive implant, we go with the Basal Tornado, the smooth surface compressive implant, and only the 3 mm implant, not more than that. And we place the implant in pair. When we are doing the full mouth case, if we are placing the nerve bypass on one side, we do it with two implants together, either classic or tornado. We do the two implants on this side, two implants on this side.
Okay.
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 You want to see the bending of the implant? I will show you afterwards.
This
We have
again.
also the basal. We have also the zygomatic implant. Ma'am, please wait for 5 minutes. I am just wrapping up the presentation. 5 minutes. So we have the zygomatic implant as well. So the implant is the basal vampire ZSI. That stands for zygomatic screw implant. It's the vampire implant that is available up to 60 mm in length. Got it?
Yeah.
Clear?
Yes.
Yes.
So these are the basal compressive implants. So we have two compressive implants in our catalog. One is the basal pros and the other is the basal varios. Basal pros pro. Pros and pros pro. So what is there? This is the compressive implant as Dr. Hashim has mentioned. So what it does is we do the narrow osteotomy. Okay. And because of the taper of the implant compresses the bone around it and produces a very dense bone around the implant. So this gives the implant a very high stability and the implants can be loaded immediately. From the other compressive implants that are present in the market, our implant has dual thread design. Okay. And there is also
Bros
a
Bro is compressive.
Pros and Pros Pro. These are the compressive implants.
Okay.
So the Pros Pro is self-drilling and self-tapping implant. So you does
What's the
not need to.
difference
I will tell you on the
again?
model. I will tell you on the model.
Okay.
I will finish the presentation.
Okay.
So I have also
Thank
announcement
you
to
so
make.
much.
I will have an announcement to make. I am launching training programs across the world. Okay, I do training in India. If anyone is interested, they can contact me up. And in the next year, we will be doing the courses in Egypt as well as Dubai. So if anyone from the Middle
Okay.
East wants to join, they can join me over there.
When in Egypt? January.
And
When in
February.
January?
The dates are to be announced yet.
Okay. Can you please place your social media, Facebook and
You can take this, please.
or
Take a screenshot of this.
okay.
These are contact number. If you are interested for the course, you can contact on these numbers. Okay. Or you can write an email on this email ID.
Okay, sir.
Okay. So I am sure what I was telling you. So the focus will be on advanced basal implants technique, the thread designs, the drilling protocol, patient selection, and the prosthetic protocols. Okay. And those who are unable to attend in person, we have an online training also available. So
Doctor,
if
if
you
you will,
can't come,
There is any books? Any books, sir, you advise us to read, or do you have any book?
so basically the books on basal implantology are about the lateral basal implants. This was the older technique, not the latest technique. So this is an older technique. So that is not much helpful in the screw type basal implants. So I'm writing a book and that will be out somewhere in the middle of the next year.
Doctor, if you will do this course, for how many days this course?
3 to 4 days.
And
How
there is
to do
workshop?
online courses?
Sir, online course will be of a longer duration, approximately 6-7. Because online we do 1 hour 2 hour per day, so that will be the course will be completed in 4 or 5 days, approximately a week. When we are doing the physical course, so that will be for 3 days, in which we will also be doing the patients.
Okay.
So if anyone wants to join the online training, it is also available. We will send you these models. Okay, the models I was telling you, we will send you these models. We will send you the kit. We will send you sample implants as well. Right. So in the training, I will show you on the model. You will do the drilling on the model yourself and show me on your camera.
Okay. Okay.
The whole kit will be sent to you, so you can practice these techniques on the model.
Okay, I want to do
On
this.
the models, yeah? On models, okay?
Hanji, yes.
On models.
Online we can be done on the models only now. So the physical
Who will,
training we can do on the patients. If you are doing online, the models will be sent to you with the implants and the surgical kit.
who will see and we will do by ourselves?
Online courses and to practice in model. I
Practice
want
in
to do online.
model, right? And I will
Yeah,
also
yeah.
What
see
is
what
the
when
cost
you
of this implant?
yes.
What is the cost of this implant?
Ma'am, I have given the numbers. Okay, these are our sales representatives are okay. So these handle all the sales. So you can contact them and they will tell you. I don't deal in the sales directly. Okay, I am the training mentor and technical director for the company. These are the sales representatives. So you can contact them and they will give you a very nice package on the implants. Okay, there are some few more announcements. Just give me a minute. So the modules I have said, everything will be covered in these modules. The troubleshooting, the complications that can come, how to deal with the complication. You will also get a certificate upon the completion of the course, whether online or offline. In both cases, you will get the certificate of completion. And we are also open to conducting these courses in. Ma'am, please mute your mic.
Doctors, PDF in the seminar.
Ma'am, just wait on a minute, please. Let me complete. So we are also open to conducting these courses in various countries. So if you are interested in having a course in your country, please contact us. In whatever country you are, you can we can form a partnership together and organize the course, conducting a training worldwide. So if you have a clinic in some country, you want to organize a course over there, and you have some friends also like 4, 5, 10 doctors who are interested in having the course over there. So I will come to your country and conduct a course over there. Got it, everyone?
Yeah. But
Thank you,
So
doctors.
why choose our let us wind it up. So these are the contact numbers. Okay, I thank you, Bonanker, for having such a nice lecture being organized and bringing together so much of leading dentists around the world on the same platform. So we should all thankful to the Bonanker Implant Company. This is my contact number. Anyone wants to have this, please write +91. My number is visible.
yeah, is it WhatsApp number?
It's WhatsApp now +91 771
Not
7
visible.
6 4 2 3 3 4। निष्ठा मैम मेरा नंबर डाल देंगे प्लीज आप ग्रुप में एक बार मैसेज में।
ठीक है सर, डाल देती हूँ।
Please check your comments. My number will be up in the comments any minute now. Everyone got my number?
Yeah, got it.
That's my number in
Can you
the
give us
message.
your
Okay, now I will be switching on to the tabletop and I will answer your questions now.
Sir, what if implant perforated into nasal cavity? What
Nothing to
have
worry.
to overcome complications?
No complications, ma'am. I will show
Okay.
you on the model. I will show you what are the possible complications that can arise.
Then how to treat also tell, sir.
Ma'am, ma'am, देखो, being a good surgeon, we should always avoid getting into complications, right? We should master our techniques very nicely so that there is no complication when we are doing the patient.
Okay.
Am I wrong?
No, sir. That's
Okay.
right.
So my tabletop is visible.
Yes, sir. Yes.
Okay, nice. So first we will, I will show you the pros and the pros pro.
Okay.
So this is the pros implant. This is the rough surface compressive implant. Visible to everyone?
Yes, sir.
So it has dual thread. So that basically what it does, it increases the compression of the implant. Please mute your mic, everyone. Right. So it gives very nice compression. The torque and the compression received with this implant is 41% higher than any other implant in the market because of the patented dual thread design. So you get very good torque even in very soft bones, right? And there is also one thing, there is single drill protocol with the pros implant. You only do the pilot drill. So I am telling the protocol of the pros implant. So this is the first cortex. This is the second cortex. We don't need to engage the second cortex. Nothing. Right? So we will start drilling here. We will have to go to the full depth on which we have to place the implant. Okay? Like we want to have the 15 millimeter implant, so we have to drill 15 millimeter inside the bone. Then we will directly select the implant based on the density of the bone. If the density is D1, D2, we go with the 3.6 mm compressive implant. If the density is D2, D3, 4.1 mm compressive implant. If density is D4, D5, 5 mm compressive implant. So the length we know before. The length is pre-planned. Length equal to pre-planned. Diameter on site during the surgery. Got it? I'm not able to understand you.
Can we bend any diameter implants?
Yes, sir. In our system, we can bend any diameter implant. The neck is standard 2 millimeter neck, so you can bend any diameter implant.
Okay, sir.
The size cannot we take it from the CBCT?
how to
No,
bend,
no.
please?
The size cannot be taken from
It's on
CBCT.
site. On site.
On site during the
And
surgery.
the torque is 45. Must be 45 for
Sir,
immediate loading.
that depends. How many teeth are you replacing?
If I'm
Okay.
placing full arch.
Right. So, sir, in full arch, the concept is different. When you are doing single tooth, minimum torque is round about 35 to 40. This is minimum.
It's for immediate loading or for delayed?
Immediate. Sir, because the implant has dual thread design, na, we always get more than 40 mm torque. Always, always. If you select the right diameter, you will always get a torque with this implant that I personally assure you. if you follow all the steps that are being taught in the training properly, you will always get the torque above than 40 for sure.
Okay,
Sir,
for
this torque
compressive,
of
what is the torque that I cannot exceed? From
Sir,
to
let me tell
55?
you, 40,
Okay.
40 45 is preferred. Minimum this, preferred this. Max,
45 torque is only for the pros implants or any basal implants?
what sir?
45 torque is only
Hmm?
for the pros implant or any.
Pros. Basal में sir in basal the torque is above 50 always, 50, 60, 70, 80.